Hi, and welcome to the show. Rate and review at kevinmd.com/rate. Subscribe at kevinmd.com/podcast. Today in the show, we have Ani Rostomyan. She is a nutrigenomics pharmacist. Her KevinMD article is titled, "In Light of Chris Hemsworth APOE News, Don't Panic." And APOE is the gene that's associated with an increased risk factor of Alzheimer's disease. Ani, welcome to the show.
Thank you, doctor. Thanks so much for inviting, and I'm really humbled to be here.
So we'll get into your article in a little bit. First off, briefly share your story and journey to where you are today.
Absolutely. So I have been a clinical pharmacist for many years. I've worked in ambulatory care for probably 6+ years, and patient care is my passion. Pharmacy is my passion. I love what I do. And recent years, I got very much involved in precision medicine, and I could probably surely say to our community that the precision medicine era has begun. Thanks to Human Genome Project that was completed in 2003, we are actually considering genetic differences now when we are prescribing, therapies, and genetics is now considered one of the factors to predict drug response. And I'm very proud to be living at this day and age where I can actually help physicians, help my fellow pharmacists to identify the drugs and perform the pharmacogenomics and nutrigenomics testing to identify how else can we prevent adverse drug events. Because at the end of the day, our mission is to cause less harm, prevent medication-related, adverse events, and provide better outcomes for our patients. So that's, in short, is my story where I am now after, ambulatory care. Now I'm fully, involved in precision medicine.
All right. So tell me more about that intersection between genomics and pharmaceuticals. So what are some typical cases that clinicians would consult it in? What are some common scenarios that you would encounter?
Absolutely. There are more than 200 labeled medications by FDA. Absolutely. There's much more than that. But at the moment, we have more than 200 medications that are recommended, and some of them are even mandated by FDA to perform genomic tests before prescribing. One of the very core examples would be, a medication for epilepsy, carbamazepine, clopidogrel for a lot of cardiovascular, related situations. But one of the core examples I want to bring out today is opioids. This is a national epidemic we have in our country, and opioids are heavily involved in persons, not only the way they respond due to their age, gender, ethnicity, but also genetics. And what we've seen recent years and more with research is that sometimes we falsely label our patients becoming addicted and becoming addicts to opioids. But in the reality, it might be even their genetics, the way they're metabolizing, certain opioids, consequently having poor or even stronger drug response. And some of the situations when they're ultra rapid metabolizers, they may even metabolize the medication much faster than they should. And we see adverse effects. We see a lot of patients seeking more and more doses. So I think the biggest example at the moment we have in our country is to address, especially with codeine containing, medications, why not include genomic testing before prescribing to avoid, overdoses in some instances. So that was the biggest examples, but there's so much more, especially, nowadays we have Plavix example where clopidogrel is heavily involved in, genomic predisposition in South Asian Pacific Islanders, where the label of the medication says absolutely perform genomic tests before prescribing. And some of the states got in, specifically state of Hawaii got in big trouble by the manufacturer, where a manufacturer was forced to pay $800 or $900 million because they failed to test patients with that specific medication and, perform genomic tests. And some of the patients had recurrent heart attacks. So I think it's so important nowadays to consider genomic factors just the same way we consider, kidney situation, kidney function, liver function, age, gender, ethnicity. That's one of the tools now we have as pharmacy practitioners to help physicians provide more meaningful patient care.
Now, how can one go about testing for genomic predisposition for certain medications? So if I'm a primary care physician and, like you said, I wanted to test the genomic background, if I want to prescribe Plavix or an opioid, what's the next step?
Truly, there's a variety of ways to approach it. It's also finding champion physicians. I would always reach out to champion physicians who are very forward thinkers, who think of what can I do to help my patient in a more meaningful way. But testing in a reactive situation is not very prudent. So we always are preaching and promoting proactive care, preemptive medicine. If you have a cardiovascular situation, you have a patient who maybe prescribe that medication, it's always good to have the test because the turnaround time is about 5 to 7 business days in best situations. But reactive care, we kind of hope and pray that the patient will not fail the medication. So preaching preventative medicine, act before the situation happens, is the case. But again, emergency care, and I'm sure you know the best, there's no time to think of, let me think of the pharmacogenomic testing, the patient had a heart attack. So this is all about thinking ahead of time, what could happen, so we prevent the adverse drug reaction. And most importantly, the reason I wrote the article in one sitting, when I read the news about Chris Hemsworth, I kind of was not really happy about it, because prudent use of genomic testing in clinically supervised environments is what I preach. We can't just randomly assign patients and test, various gene biomarkers and kind of create more of a mental health and psychological distress on patients where, it wasn't needed, right? There was no indication for use. That patient probably had no family history of Alzheimer's disease. He's a young, productive, healthy individual. There would be no need for that test unless if there were really big factors prompting the physician to perform it. So that was the reason I kind of wrote it, to spread awareness that even with advancements in science and healthcare and medicine, prudent use is number one thing that we have to propagate and just push for it, not just because it's a fancy new test and, everyone should get it done, but whether the patient will benefit from the after effect and the knowledge of that. Because, right, he took some time off from acting, what if it was his most productive years and without any history? Why would he need to do it? I'm sure there's more to it, but this is the reason, as a precision medicine pharmacist, I wanted to put in my opinion on sometimes more is not good. More information is not a good thing.
Let's talk about that case. So I think that he disclosed that he took this test on one of his Disney Plus shows, right?
Absolutely.
APOE is the gene that's associated with the increased risk of Alzheimer's disease. Now, for those who aren't familiar with what specifically happened, just go more into your article.
Absolutely. So the APOE gene is quite popular nowadays. Is apolipoprotein E. There's variety of alleles, variety of forms of it. Number 4 is the one that's implied in the research about Alzheimer's disease, but it also really applies to late onset. We need to be very clear about the LOAD, the late onset Alzheimer's disease, where its predisposition is not predetermination. So majority of patients who actually are diagnosed with Alzheimer's disease at later stage in their life may not even carry that allele. So it's kind of interesting how we approach the information. Now, when we talk about the most rare, version of the early onset, which is quite rare, about like 10% of patients with Alzheimer's disease will have the early onset, there's other gene markers that are very interesting and really important in testing, because if you have a patient that in their 30s showing signs and symptoms, that's something very, more important to test. But the late onset Alzheimer's disease, and I really wanted to touch on epigenetics in this case, where our lifestyle predetermines our disease predisposition. It's not only having the genes or the mutations in like the chromosome 19, or especially in chronic disease states as well. It's our lifestyle, our environmental factors. It's much more to it than just having the predisposition to the disease. And epigenetics is, again, cutting edge science that tells us that we all carry those disease-causing genes. We all carry it, but whether we choose to live a healthier life or life full of unhealthy habits, unmanaged, weight, blood pressure, lipids, glucose, that's what determines the progression of the disease. Not just having the gene and say, oh, you know what, I can't do anything about it. Now I have the genetic predisposition. So I wanted to shed some light on, there's so much more we can do as patients and so much more we can educate our patients. as clinicians that your lifestyle what matters. And as Dr. Bruce Lipton mentions, he's the founding father of epigenetics. It's not the genes that are existent in our bodies, it's the lifestyle that turns these switches on and off. And more we know nowadays, and living in chronic disease epidemic in our country, there's so much more power to patients, telling them that you can change your life around. It's not just what you have, as a test result. So that was the mission, to advocate for patients who would get distressed and, upset about the situation, saying, why did you even order that test for me? I want to mention something very important. In clinical community, the APOE test is not really routinely recommended by, physicians who manage Alzheimer's disease. And there's very few, again, as a pharmacist, I have to tell that there's very few medications that are on the horizon to help patients. It's very sad that we don't have much to offer to patients, but imaging and a variety of other cognitive tests are pretty much the clinical, criteria to diagnose a test, not the genetic test at the moment.
Now, what do you think about those commercially available genetic tests that are often marketed? Some patients come in my exam room, they ask me, should I order these tests? Or in a lot of cases, they ordered it themselves and they come to me with the results. What's your opinion on those commercially available genetic tests?
That's a fantastic question. And as a pharmacist in precision medicine, I highly recommend against self-testing. The DTCs are not what my patients should go and kind of like read the information without the clinical background. There's very conflicted opinion on the quality of the tests and whether the biomarkers are showing true clinical validity of the outcome, because we can test anything we want. But what are the studies showing that once you know that information, what do you do to live your life without that disease? So absolutely reach out to professionals. I highly recommend against those $99 or $75, genomic tests that teach you that you have the Alzheimer's disease risk. There's a lot of other ones that are on the market. Quality may not be the same. I don't want to go against anyone to say don't use them. But again, reach out for a healthcare professional who's specialized in it and who can give you good information on what do you do with that information. Sure. Some of my patients actually with pharmacogenomics testing, they told me that they did the test on their own. They got very scared and some of them stopped their medications based on the test on their own. So the scary situation comes in that patient may change their own therapy based on that. So that's very, very big advice to whoever is listening. Do not go for those tests. And as a pharmacist who's in that practice, I recommend against routine, unnecessary use of the genomic testing.
On the flip side, let me ask you, are there clear-cut cases where patients should consider genomic testing? And if so, what are some examples of clear-cut cases?
Absolutely. That's a fantastic question. In certain ethnicities and certain clinical situations, there are medications that have very high level evidence of showing that the genomic testing is absolutely needed before starting the therapy. I don't want to name the medications, but again, with even carbamazepine, right? We know several of, patients of Asian descent, SJS, TEM, there are situations that we can save lives by providing the genomic testing. It's not really embedded in clinical practice at the moment. I've seen a lot of patients working as a pharmacist on that specific medication where doctor mentioned, if you develop rash, stop the medication. So that was not enough for me. I would probably say, let's not wait until the rash happens. Let's absolutely test, or abacavir, the antiviral medication. That's very important if that test is performed, because we have evidence. And what we need to practice absolutely by clinical evidence that shows reliability, that shows that yes, if the patient is using the medication, the genomic testing, absolutely is needed. Another example would be the anticoagulant warfarin. An absolute genomic test is required before we start therapy. So those cases, no brainer. We absolutely need to use the advancements in, science and medicine, but just routine tests for healthy individuals without taking any medicines, I kind of recommend against it.
Now, in the primary care setting, how do we go about ordering a genomics test? Is this something that we have to find a precision medicine pharmacist like herself? Do we go to a genetic counselor who will then order the test? What's a typical workflow for that?
That's a great question, because some institutions like St. Jude Children's Hospital, they already have embedded in their practice because they're so focused on, oncology, and the, scientific evidence in oncology for genomic testing is quite high. So that's number one, pool of evidence. The rest of the situations, we're still in progress to kind of advocate for our profession and say every hospital needs a pharmacist who will be specialized in pharmacogenomics to kind of route the information to the right direction. Sometimes I see that some institutions may have clinical decision support tools embedded in their software, where when physician starts prescribing the medication, it pops up as an alert that pharmacogenomics test required, actionable drug gene response may be of very high importance. But at the moment, the field is new. There's a lot of advocacy we do in states to at least have some insurance coverage for patients, for the testing, because, the test is very expensive. And a lot of underserved populations, specifically in California, we have quite a high percentage of people who are unable to afford the $350 test. We keep advocating for it because I just had a patient last year whose Medi-Cal, which is the California state Medicaid, covered the pharmacogenomics testing, and he had zero, copay. He was happy because we had a significant list of trial and error it was a psychiatry patient. So in those instances, it's absolute medical necessity. They cover the test, but generally it's a lot of work. We have to advocate statewide, nationwide to kind of, get where we have to be.
And my final question, what are some of your take-home messages that you want to leave with the KevinMD audience?
Oh, fantastic question. I think my biggest message to, clinical community is I have great respect for physicians at this day and age who worked and work in these unimaginable conditions. I want to give my greatest shout out to champion doctors who survived, on crazy times the last 2.5 years. I think that the practice of medicine is changing. We're a good team. We're an interdisciplinary team that is working around the patient. Things are changing. Science is evolving. We have to really work together to make some of the sad situations, especially my passion, chronic disease epidemic, to educate our patients and change their mindset. And I feel like pharmacists are good, team members in that realm, where we are another route of information that we can teach our patients. And the good things are yet to come, but we have to stay strong because challenging times are not over yet. So my message is that we're one team. We work together, revolve around the patient to make them healthier.
Ani, thank you so much for sharing your time and insight, and thanks again for being on the show.
Thank you, doctor. It was a pleasure.